Good afternoon. My name is Anett Rancz, and my thesis is the invisible presence microscopic colitis. I am a second-year PhD student in the group of gastroenterology and endocrinology of the CTM, and I am also an SMS for the first-year students from the gastro group. In my vision, some vigilant physicians educate patients to prevent the development of the disease, microscopic colitis. For that, my mission is providing professional knowledge about the clinically relevant risk factors of microscopic colitis. For that, I have two ongoing projects. My first topic, microscopic colitis is a risk factor for low bone density. In Europe, the prevalence of microscopic colitis is around 119 cases per 100,000 persons. There are many confounding factors regarding the relationship of microscopic colitis with low bone density. First of all, both diseases are more frequent in elderly women. Moreover, women in menopause can receive hormonal substitution treatment, which in turn can cause microscopic colitis. Furthermore, budesonide, the gold standard therapy of microscopic colitis, is a corticosteroid with low systemic bioavailability due to its high first-pass effect in the liver, but still it has been implicated in a long-term therapy with the development of LBD. So our aim is to scrutinize if microscopic colitis is a risk factor for LBD development. We put our clinical question and we applied the two frameworks, the PECO and the COCOPOP. We made our systematic search on the 16th of October 2021 in 5 databases, and we got around 3,000 hits. Our search key was constructed from 2 main parts. The first part contained microscopic colitis and the 3 subtypes of it, while in the second part we included osteoporosis and the synonyms of it. Eventually, the number of included studies in this review was 4. Our first outcome was if MC is a risk factor for LBD development. We investigated MC patients compared to age and sex-matched controls, with a 37% moderate heterogeneity, presumably due to the Rancz study, which has a cross-sectional study design with the youngest population. Our overall measurement, the odds ratio was 2.13, which means that microscopic colitis doubles the odds of low bone density. We made additional analysis where we omitted the Greenberg study, which was only a conference abstract, and it resulted in a 2.96 odds ratio, which means that microscopic colitis triples the odds of low bone density. LBD has 2 forms. The mild is osteopenia and the severe form is osteoporosis, and its clinical relevance is that osteoporosis can culminate into osteoporotic fractures. So in our proportional analysis, we investigated MC patients with low bone density with a 75% considerable heterogeneity, presumably due to the Greenberg study, which was only a conference abstract and had the oldest population. It resulted in a 0.68 proportion. We have MC patients with osteopenia, and the proportion was 0.51. And in case of MC patients with osteoporosis, the proportion was 0.11. It means that almost 2/3 of the MC population have low bone density, half of them have osteopenia, and 1 in 10 MC patients has osteoporosis. All of our outcomes are at a very low level on the certainty of evidence scale after the Grade Pro guideline due to the small sample sizes and because the included studies use the surrogate outcome measuring the bone mineral density. The strength of our study is that this is the first comprehensive picture which gives the relationship of microscopic colitis with low bone density. All the included studies use the DEXA to measure bone mineral density, and we apply the rigorous methodology. On the other hand, we have some limitations as well, like a small number of studies with different study designs, low number of study participants, and a female predominance. Ultimately, we did not have enough data to put together the adjusted odds ratios. In conclusion, we highly suggest screening patients for bone mineral density at the moment of diagnosis. Based on our findings, we can recommend lifestyle and dietary changes in case of osteopenia, calcium and vitamin D supplementation, and we also recommend impact exercise combined with resistance training, because it was shown that this fits the best for pre- and postmenopausal women to maintain their bone mineral density. As regards of implications for research, further observational studies, incidence studies, international and national registries are needed with bone mineral density follow-ups. We traveled a long way together with my team, but currently our manuscript is submitted to the American Journal of Gastroenterology, and the status of it is under review. During that time, we are harvesting the fruits of our labor by attending conferences. We suspect that microscopic colitis is a really underdiagnosed disease, which might be one reason for having small sample sizes in our previous investigation. On the other hand, most of the included studies lacked confounding factors, which might be the risk factors for microscopic colitis. So we wanted to investigate these aspects of the disease. Just a few words about the background. In Europe, the incidence of microscopic colitis is around 11.4 cases per 100,000 person years. Some lifestyle factors like regular alcohol consumption can result in mucosa impairment, which causes non-infectious diarrhea, which is notably more frequent in the elderly population. Moreover, the risk of incident MC due to smoking has been already detected. However, the pathogenesis which stays behind this phenomenon is still lacking. Furthermore, the medication use has been implicated in the development of LBD. So we aim to assess the risk factors of microscopic colitis in adult patients. Our clinical question is, what are these risk factors? We apply the PEO framework, and we hypothesize that in the presence of the risk factor, the odds of developing microscopic colitis are higher. Our clinical implications are screening and prevention. We made our systematic search on the 18th of December 2021 in 3 databases with the search key only containing microscopic colitis and the 3 subtypes of it. And eventually, the number of studies included in this review is 29. Now, let me show you some of my results. In our first analysis, while investigating the mean difference of age between the MC and the control group, we have found that MC patients are older with a 6.37 mean years. In our next analysis, where we investigated the female sex, we have only found an increase, a significant increased odds in comparison to random controls. So the value was 2.52 of having microscopic colitis if one is a female. No significant results were found in any of the above or below secondary school education groups. Regarding lifestyle factors, the alcohol consumption, we could only compare the MC controls to random, the MC population to random controls, and it gave us no significant result either. Investigating the current and the past smoking among microscopic colitis patients compared to controls. If one is currently smoking, the odds of having microscopic colitis is 1.64. And last but not least, if one is taking nonsteroidal anti-inflammatory drugs, the odds of having microscopic colitis are doubled. So my goal is to submit my second project during springtime of 2023. And I would like to close my presentation with the words of a great singer: there are no shortcuts to any place worth going. Thank you. And if anyone has questions, I'm glad to respond.
So regarding the first topic, the osteoporosis and microscopic colitis, okay, we should test everyone at diagnosis. And how often should we repeat the test? What should be the duration of repeating the test if, let's say, if we find no low bone density in our patients?
Thank you for your question. If at the moment of diagnosis there is no decrease in the bone mineral density, I believe that it should be only considered to do a new DEXA if the patients have an inquest for that, or it is suggested by the GP or the physician who is taking care of that patient, taking into consideration also like if the person is taking like hormonal therapy or like doing physical activity or taking D vitamin in plus, so these aspects should be considered.
Thank you. Any other comments, remarks?
I have a short question, just what is the diagnostic process of microscopic colitis? So it's a colonoscopy, or what is the gold standard for that diagnosis?
Thank you for your question. The diagnosis of microscopic colitis is based on a histopathological concept. So a colonoscopy by itself is not enough. This is why I have also chosen the invisible presence. While doing colonoscopy, you can't put the diagnosis, so it is only based on a histopathology.
Any other comments or questions? If not, then, oh, yeah.
Sorry, I don't really know too many things about microscopic colitis. So can you please describe when you think about this disease and when are you searching for signs of microscopic colitis?
Thank you for your suggestion and the opportunity to increase the awareness of the listeners of microscopic colitis. So it is characterized by chronic watery non-bloody diarrhea, and it comes concomitantly with many stools during nocturnal time and some discomfort of the abdominal part, but mostly it is more prevalent in elderly female persons, and also like we don't really know the pathogenesis which stays behind it, but they say that some luminal factors, the genetic background, and also the autoimmune dysregulation are taking place on the basis of how it develops. But there is always a trigger, but we are not sure of it. This is why we are also investigating like the risk factors.